Next is the dementia with Lewy bodies, which is a progressive neurodegenerative disease characterized by the abnormal collection of alpha-synuclein within the neurons, and it is one of the two Lewy body dementias along with Parkinson's disease dementia, which I will discuss later. The presentation is usually comprised of core clinical features and other supportive features. The core clinical features include fluctuation in their cognition, recurrent visual hallucinations, REM sleep behavioral disorders, and Parkinsonism. It may exhibit premotor symptoms similar to Parkinson's disease, usually 10 to 15 years before the cognitive decline may present. Other supportive clinical features include marked sensitivity to antipsychotics, marked dysautonomia, hypersomnia, hypoosmia, postural instability, and frequent falls. They may also present with a lot of apathy, anxiety, and/or depression. So it is considered the third most common major neurocognitive disorder in older adults after Alzheimer's and vascular disease. The incidence and the prevalence are not known accurately, but it's roughly 0.4% of those more than 65 worldwide. There is no exact trigger for the buildup of the alpha-synuclein. Family history is actually not common, but the heritability can be up to 30%. One risk factor we know of, aside from advanced age, is the ApoE4 allele, while ApoE2 seems to be protective. There are other genetic mutations that may cause it as well. So the pathology is simple. The alpha-synuclein keeps accumulating in dopaminergic neurons with neuronal cell death, impairing their behavior, their cognition, their mood, their motivation, and their sleep. And then it starts affecting the acetylcholine neurons, causing memory and learning problems. Brain atrophy and pathology seems to be worse than Parkinson's disease dementia, but not as bad as Alzheimer's disease. So according to the fourth consensus report, a diagnosis of probable dementia with Lewy body requires the evidence of dementia, at least two core features that we just mentioned, and at least one biomarker, which may include a low DAT3 uptake on the PET SPECT scan, which is also known as a positive DAT scan, or a low 1 to 3 iodine meta-iodobenzyl guanidine uptake on the myocardial scintigraphy, or loss of atonia during REM sleep on a polysomnogram study. Other supportive biomarkers include an intact medial temporal lobe on brain imaging, because it's usually affected more in Alzheimer's disease and some cases of frontotemporal disease, reduced occipital activity and high slow-wave sleep on EEG. For some clinicians to differentiate between Parkinson's disease dementia and dementia with Lewy body due to the similarities between them is using the 1-year rule. So if the cognitive decline started within 1 year of the Parkinsonian features, then it's probably dementia with Lewy body. If the cognitive decline started more than 1 year after the Parkinsonism manifested, then it's probably Parkinson's disease dementia. So unfortunately, dementia with Lewy body also shows rapid progression, especially if they have one of the alleles for the ApoE4. Orthostatic hypotension, visual spatial deficits, and gait instability usually correlate to worse prognosis due to recurrent falls. Compared to Alzheimer's disease, they have higher rates of disability, lower life expectancy, worse quality of life, more neuropsychiatric symptoms, and an average survival time after diagnosis is between 4 and 10 years. The cause of death is primarily related to falls and failure to thrive. There is no treatment, no cure. The outlines of care are similar to the 3 pillars we discussed for management of Alzheimer's disease. With symptomatic treatment becomes more challenging due to the fluctuations of their symptoms, limited response, and marked sensitivity to antipsychotics. You have to also exercise extreme caution with the use of dopaminergic agents, which may worsen psychosis, using the acetylcholinesterase inhibitors, which can worsen the autonomic symptoms, and the use of antipsychotics may cause extrapyramidal symptoms up to neuroleptic malignant syndrome. Next is the other brother of the same family, the Parkinson's disease dementia, which is a chronic progressive neurocognitive disorder that is associated primarily with Parkinson's disease. So it usually starts with Parkinson's disease for at least 1 year, and then changes in cognition start to manifest. Usually it presents with more tremor, and it's less symmetrical than dementia with Lewy body. 80% of patients with Parkinson's disease have dementia in later stages. Delusions in Parkinson's disease dementia are less common compared to dementia with Lewy body, and the severity of the visual hallucinations are less prominent. Non-motor symptoms or premotor symptoms may include depression and apathy, constipation, orthostatic hypotension, incontinence and erectile dysfunction, and excessive sweating. So the pathology, the etiology, the diagnosis is very similar to dementia with Lewy body. The prognosis and treatment tends to be slightly more favorable than dementia with Lewy body.